And then I'm going to do the Facebook Live. Give me 1 second here.
Where you record, is Dr. Mahfouz on?
Hold on.
He should be joining us in a minute. I just texted him.
Okay.
Actually, I could have did this before. That's what we talked about. Okay, I'm gonna go live. Okay, I believe we are live.
Yeah, I can see it.
So I'm going to admit this person. I'm going to mute everyone, and then I'll choose to unmute as we move along. Okay. Okay. All right. Well, we're going to go ahead and get this kicked off here. Welcome everybody to the Epilepsy Center's Purple Day event, an evening with the doctors. I am Roy Cherry, the CEO of the Epilepsy Center of Northwest Ohio. And tonight we celebrate Purple Day with a great opportunity for an open discussion with our leading neurologists in the Toledo area. One of the brief things I want to mention about Purple Day itself is it was started by Canadian Cassidy Megan, and she really wanted a single day that created a recognition across the world about epilepsy and awareness about epilepsy. And with purple being the color for epilepsy, she called it Purple Day. And so we try to wear purple. There's a lot of other events going on all across the world about epilepsy awareness. And so every March 26th is Purple Day. And she was really helped kicking this off with the Epilepsy Association of the Maritimes and Anita Kaufman Foundation out of New York. So that really helped it become possible. So at this time, I'm going to turn it over to our moderator for tonight. She's our board member of the Epilepsy Center of Northwest Ohio, Nicole Giudici, and she is going to introduce the doctors as well as moderate the questions that come in. And she has a number of questions that have come in over time, and she's going to be doing that. So I'm going to turn it over to Nicole. Nicole, it's all yours.
Welcome everybody, and thank you for spending your Friday night with us. Just to introduce our panel of doctors tonight, we have Dr. Zhang, is a neuromuscular medicine specialist with Mercy Pediatric Neurology Specialist in Toledo, with over 39 years of experience in the medical field. Dr. Mahfouz is with ProMedica Physicians Neurology in Toledo. He's board certified in neurology with a special qualification in child neurology and epilepsy. Dr. Nagel is a pediatric neurologist with ProMedica Physicians Neurology in Toledo and has over 38 years of experience in the medical field and has previously served on the board of directors of the Epilepsy Center of Northwest Ohio. Dr. Sheikh is with ProMedica Physicians Neurology in Toledo and has a certification in epilepsy and a certification in clinical neurophysiology, and also has a special interest in sleep. Dr. Soraya is a clinical neurophysiologist at Toledo Clinic. She specializes in general neurology, neuroimmunology, multiple sclerosis, and neurophysiology. Dr. Soraya is currently on the board of directors for the Epilepsy Center of Northwest Ohio. And Dr. Riaz is with ProMedica Physicians Neurology in Toledo. She specializes in epilepsy, clinical neurophysiology, and is board certified with the American Board of Psychiatry and Neurology. So welcome all of our physicians. We have received a number of questions ahead of time. So in order to make things move along quicker, we're going to jump right in, but I want everyone to know that they can send us their questions live in the chat function, and I'll be monitoring that throughout tonight's program. So don't be shy and feel free to send us your questions. And to kick it off, let's start with why does my doctor want me only to take the name brand seizure medicines? For example, does not allow me to take generic medicines. Which one of our panelists would like to take that one? Dr. Soraya. I think we're all muted, Roy.
Yeah. Well, thank you, Nicole, for a kind introduction. And so to kick off, I think this is a very important and common question that we get asked. As you know, for everybody's understanding, and most of the panel that I see is more physicians, so I don't need more introduction. For those who are not, the medications are made in a very specialized way in pharmaceutical industry. And when these medications are made, a lot of quality control and a lot of minute details are taken into account. And so when the medications are made in the facilities where some of these are probably not done properly, or sometimes the medications are patented and the quality control may not have happened, that you assume. Studies have shown that, medications that are taken on a generic form, they deviate 10% of the levels that you measure in the blood from what you have seen in the setting when they have taken it in the brand name. So if you take 10% much more, it can make you toxic, or if you take 10% less, it will make you subtherapeutic, which means you're taking less what is needed, and it can predispose you to have seizures. Although this variability is considered to be okay in certain situations, and sometimes insurance companies, suggest that you take generic because they find them to be cheaper. Since going on a generic medication predispose you to have seizure, and having seizure is not considered to be a good thing. It can be very life-threatening at times, and so it is recommended always by the epilepsy doctors to take brand name medicine versus generic. Although there are some, exceptions that, cost and other factors that needs to be looked at. So that's the reason why they do that.
Thank you, Dr. Soraya. Dr. Riaz, I think this question would be a good one for you to answer. How do you know I have seizures/epilepsy if my EEGs are always normal?
Sure. So seizures or epilepsy, we usually tend to try to diagnose or figure out what's going on based on the clinical history. So if you're describing what sounds clinically like a seizure, then I would assume that you had a seizure. And if you have more than 2 seizures that are unprovoked, or if you have a seizure with a known brain lesion or an epilepsy condition, then you're diagnosed with epilepsy. The EEG is not a perfect test. It's a test, it can be a 20-minute study, a 1-hour study, a 6-hour study. So it's just a snapshot of what your brain is doing at that point. If someone has very frequent seizures and very frequent epilepsy, then that EEG may show me something immediately. And if someone has infrequent seizures, that EEG might be normal. That's why we do repeat it up to a few times. We can try to do ambulatory EEG, which is a long EEG in the outpatient setting, over the course of 2 to 3 days. Or we can admit you to the hospital for a very prolonged EEG where we watch you for 5 days or so. With that said, the clinical history is the most important. If you're describing something that sounds like passing out, I would say you're passing out. If you're describing something that sounds like it's a seizure, that's what I would think is going on. The EEG can help us diagnose it, but it's not definitive.
Thank you very much.
Yep.
Our next question is for Dr. Sheikh. My child only seizes during the sleep-wake cycle. In your experiences, will this likely stay consistent, or have you seen these types of seizures develop into daytime or wake cycle seizures with age?
Okay, it's a very good and very common question. A lot of seizures, tend to happen when there is a change in the state of mind from either sleep to awake or awake to asleep. The theory behind that is that when the brain is waking up from sleep, there is a heightened, tendency for seizures because of certain, chemical instabilities in the brain as we are waking up from the sleep. So that's a very common phenomenon. The seizures happen more when the patient is waking up from sleep. There are certain epilepsy syndromes in particular, like syndromes like juvenile myoclonic epilepsy or other generalized epilepsies, which are more likely to happen mostly in the morning. And that tendency tends to stay with those kind of epilepsies lifelong. So if it's one of those epilepsy syndromes where the patient has what's called a generalized epilepsy syndrome, means the whole brain is irritable and has a tendency to cause seizures, then those kind of epilepsies tend to have a lifelong association with waking up from sleep. If it's one of the other epilepsy syndrome, not one of the generalized epilepsy syndromes, then it's possible that that characteristic might change with age, and the patient may no longer be sensitive to sleep deprivation, with age. So all depends on what kind of epilepsy this patient has. If they have, in short, generalized epilepsy, then it's very possible they might stay with that tendency of having seizures, waking up from sleep.
Thank you. Dr. Zhang, sometimes I forget to take my seizure medicines. Is it really a big deal if I miss 1 or 2 doses of my seizure medicine?
That will depend on which medication. So because every medication, the half-life is different. So if like a very long half-life, if you miss one dose, it may not big a deal. But if a short half-life medication, if you miss one, the blood level drop will quickly. So that's what we're not good. But definitely we always say, it's better not to miss medication.
Thank you. Dr. Nagel, why can't I drive for 6 months after I have a seizure?
Well, that's a complicated question. It is a public safety issue. Each state has varying instructions about how long you need to be seizure-free before you drive. But what we look at and what the states look at is basically if somebody is thinking they may not necessarily know they are about to have a seizure, and if you're driving, you could get into an accident and cause serious injury or death to other people. As far as should it be a week, should it be 3 months, should it be 6 months or longer, each state has different rules about that. The general feeling is that the risk of having a seizure while you're driving is a function of how often you drive and how often you have seizures. And most states, not all, but most agree that 6 months is probably a reasonable period of seizure freedom to allow somebody to drive. There are states that may put the restriction at 1 year or even 2 years, but the general consensus is 6 months, and it's a public safety issue.
Thank you. Dr. Mahfouz, can I go swimming if I have seizures?
Certainly, you can do swimming in a swimming pool, but you have to make sure that someone is watching you, that in case of any emergencies, someone can come and help you. On the other hand, swimming in the lake or in the ocean, that's a separate issue. In those kind of situations, for example, there are people who go to the boat, and I always tell them, you don't forget to wear your life jacket. It doesn't matter how good of a swimmer you are, but safety is a concern. So there is no restriction in swimming, especially in the pool, but as long as someone is watching you.
Thank you. Dr. Soraya, this may be a good question for you, or anyone can jump in at this point. Regarding the mRNA versus adenovirus vector vaccines, specifically for COVID, I lean toward mRNA. However, I'm concerned about the dosage for medically fragile patients and children. Do you feel the dosage affects the severity of reaction and might be considered a factor in pediatric vaccines?
I will pass this to the pediatric neurologist in the panel.
How about Dr.
Whoever wants to
Haseeb?
take it.
Is Dr. Haseeb with us? Yes, Dr. Haseeb, take it away. Oh, we can't hear you.
There we go. Sorry about that. No, I am kind of on the pediatric vaccine. I don't know. I to be honest, we discussed this again, not trying to turf it, but we have our infectious disease folks. I usually consult with them. I haven't yet had a scenario in terms of this type of situation, but I know that we want to give the vaccine because as of now, what I know is 16 and over is what the vaccines have been approved for, and you have on one option is you get the COVID, other is you get the vaccine. And obviously, if you get the COVID, especially in someone who is medically fragile, has epilepsy, and has a higher chance of getting those seizures, I definitely would, weighing the risk versus benefits, go with the vaccine. Now, as far as the dose, would it have much more higher impact? I don't know. Perhaps somebody else could give highlight on that. But I refer to the infectious disease colleagues for that question. Dr. Jiang, have you had any experience with that?
No, we don't know what the dosage will be. Then for peds compared to adult, we don't know.
Because I know 16 and over, so it's not even means, are we having 4 years, 6 years age kids getting that? I don't think so.
So that takes us to our next question. Have there been any pediatric studies worldwide that have documented any pediatric heart or neuro patients' reactions to either vaccine?
Since they are not giving medication vaccines to the pediatrics, so the studies will come shortly. So far, in my knowledge, I do not know. I don't think we have enough data at this time regarding pediatrics. The only issue, and now very soon we will be giving vaccines to pediatrics, especially the COVID vaccine. So there is just one point I just want to highlight, that when you get, I will take like even COVID as like febrile illness. And any kind of febrile illness and under these things, basically they reduce your seizure threshold. So and you will have a chance of having more seizures. So one of the things which we can do, whether you get COVID or you get the vaccine, if you get the vaccine, majority of the people get the reaction, and that reaction is limited. It lasts for like 1 to 3 days. So in those kind of situation, what we can do, we can either start a prophylactic clonazepam. That will be one approach, or we can tell them to take a Tylenol and Motrin alternatively. Usually there is also a thinking that not to take too much of Motrin. That is also one thing. The other thing is that during those times, it will also be a little bit reasonable approach to increase medication level a little bit for few days, and then after the period is over, risk period is over, then you can bring the seizure medication down.
Thank you.
Right. And I just want to add to that is that as far as the studies, because the reason it's approved for 16 is those studies did include children who were 16 and over. But the studies between 12 and 16, there is not yet data. And as Dr. Mahfouz said, that still ongoing trials are happening though. They are. And I was just able to pull up an article which does talk about the EU has a Pfizer study that's going on for kids between 12 and 16. And then there's another study that's going on, including babies as young as 6 months. And they're expecting to enroll 6,700 children in the US and Canada together. So that's ongoing. And in the next couple of months, those data will come out. So stay tuned for those results.
Thank you. Dr. Mahfouz, a clarification on our previous question we had for you about swimming. Do I need to wear a life vest every time I swim if I have seizures?
It depends. It depends on the, for example, the swimming pool. When the lifeguard is on board, I don't think so. You can swim without it. But going to an open environment like a lake, those kind of situation, I would highly recommend life jacket. But even in that situation, the help should be around you.
Yeah, this is Dr. I agree with Dr. I'm sorry. I agree with Dr. Mahfouz about the swimming issue. The biggest question that I get from my patients has to do with swimming at a beach where there's surf, swimming at a lake, and I label those situations as swimming in black water where you can see the bottom. So it's going to be a rescue issue if you have somebody having a seizure while in those situations. I don't strongly advise people to wear life jackets, but it's probably prudent. And the other question is, if you wear a life jacket, what kind of life jacket should it be? Life jackets have different designs, and the safest designs for people who are prone to seizures are the ones where if you are unconscious, it'll keep your head above water. And sometimes that is those old-fashioned Mae West jackets, that the orange ugly vest that they have, instead of the more sleek designs that are there now. But keeping the head above water is very important in those situations. And the same goes for boating. And by the way, anybody who has seizures should not be scuba diving. If you have a seizure while at depths where you're at risk for the bends, that will be very bad. And the consensus amongst epileptologists is that you should not, or you must not scuba dive if you're prone to seizures.
Thank you.
Can I, do you mind if I interject? Just another question on the swimming and all of that. But would it be similar to, even though there's laws about the driving in 6 months seizure free, would there be less concern about life jackets, scuba diving, et cetera, if seizures are under control for an extended period of time?
Not being a scuba diver, I can't give you a definitive answer. But one of the issues with scuba diving is that you're not putting anyone else at risk. But I do believe, as far as scuba certification, that is a contraindication. Having seizures is a contraindication to certification. But I may be wrong.
As a general common sense thing, for example, I know our teenagers, they go with common sense. So the common sense thing is that, for example, if you do skydiving, something happen in the middle of the air, who will reach there? Nobody. If you are deep inside the water, if something happens, who will reach there? Nobody. If you are on a rope and something happened to you, who will reach to you? Nothing. So any situation where reaching help is difficult, for example, bungee jumping, you just jump you go to Cedar Point and do but if something happens, so it's very hard to stop it. So in those kind of situations should be avoided. But having a seizure does not mean that you will not enjoy life anymore. It's just few things in which getting help would be difficult. Those are the situations where you have to be careful.
Yeah, I would second that, because see, I get these questions that, hey, can we do roller coaster rides? I'm going to say, if I'm going to start saying no to everything, then the patient is going to get depressed, and they're going to be like, oh my, you can remember, depression, anxiety is seen in a huge amount of population who have epilepsy. And on one hand, you also want to make sure you kind of give them a little bit rosier picture of not everything is a no for them, but also the safety is important. So for the roller coasters, I do the same thing. Hey, if you have a seizure when you are on the ride, remember, no one is going to save you till that ride is done, because it's going to be crazy ride. Everyone is shouting and they have no clue what's happening, and they think you are just having fun. So they understand that. So have I had patients who have had seizures after a roller coaster ride? I have had a few, and they took the risk. I mean, to say, ultimately, it's so you're right. If it's not controlled, it's a no. If it's controlled, still there is a huge risk, because there's a lot of excitement, there's a lot of tension, stress happening, and when your brain is going up and down, there's probably some concussions happening, and all those can kind of act as a quick trigger to have a small seizure could happen. It's a tough one. It's going to be ultimately at the decision of the patient, but they're making that choice. Maybe simpler rides. I just say them, yes, do have some social fun, but try to channelize it maybe in a different fashion. Don't do bungee jumping, but do something different, something easier, something lighter.
Thank you, everyone. That was a great discussion. Dr. Riaz, two-part question for you. If I have epilepsy, can I have children? And second part, if I have children, will my children have epilepsy?
Sure. It's a bit of a complicated question to answer, but yes, if you have epilepsy, you can have children. A lot of epilepsies, like different epilepsy syndromes, tend to run in families. Something like juvenile myoclonic epilepsy, 50% of patients have some kind of family history of it. Absence epilepsy, a lot of patients have a family history of it. So the chances of your kids having it may be increased. I don't have an exact number because there's different types of syndromes that run in different families, but you can still have children, and ideally, hopefully, knock on wood, they may have epilepsy or they may not. I may also defer this to peds who may know more about genetic epilepsy syndromes.
So actually, the average risk if a mother has epilepsy, the child has epilepsy, as the average is 5%. Not that high. Because it depends, like if definitely if you know like a single gene mutation cause that, maybe a little bit high to pass around, then yeah, but the average wise say it's only about 5%.
And also to add, if the individual has a generalized epilepsy, then the chance of passing is much higher compared to someone who had focal epilepsy.
Sure.
And then also
one
to
more thing
add
I have to
another
add.
is majority of the epilepsies are considered as genetic. Now we might have a mutation. You have those potassium channel mutations, sodium channel mutations. So you have all these different type of, and then you have the de novo variants and genetic variants with if it's autosomal recessive or dominant inheritance. There's just so many different, but majority of the epilepsies are considered to be genetic, especially if in the absence of malformations, bleeds, and any brain damage. But otherwise, yes, I say is if the mom had it or dad had it, there's a high likely chance that they will pass it on. Dr. Saraya, you were saying something, sorry.
Yeah, so what I was saying is that if the genetic of the epilepsy in the parents is known, and then they can seek what we call as a genetic counseling, and that would be true for any other disease process. But having, if a woman especially having epilepsy does not mean that they shouldn't have babies or they shouldn't get pregnant just because they have epilepsy, so that they are going to pass it to their children, even if the genetic epilepsy is known in them. So it is to be encouraged that it is safe to get pregnant and get to the pregnancy. You may have a child with epilepsy, but it's still not discouraged in
Yeah,
general.
another point, if someone has diabetes, if diabetes runs in your family, do you stop having kids? If asthma runs in your family, do we stop having kids? It's like, it's the same thing. Just like we have treatment for diabetes, we have treatment for asthma, we have treatment for allergic reactions. Similarly, we have treatment for epilepsy. So nobody is perfect. Each one of us has something. So if you have this condition, so just the main thing is to acceptance of this of the condition, and then taking proper measures how to control it. If we can do it, like, I don't think it will cause like too much impact on your life. Ignorance is a major issue. Ignorance and lack of precaution is a major issue.
And I would add one thing more to that, Dr. Mahfouz. Very good, you said. I think that also very important that, yes, you're having the kids. Maybe you could speak with your doctor into what medications, because certain medications have a higher chance of having a child with birth defects compared to others. So if someone is on Depakote or phenobarbital versus, let's say, you're going to be on Keppra, levetiracetam, or lamotrigine. So perhaps you could speak to your doctor before you're planning to get pregnant and say, hey, I'm planning to get pregnant. What do I do? Many times folic acid supplementation is required because some of these drugs can deplete your folic acid. Then you're going to have a baby with defects. And then you might think it's because of the epilepsy. No, it's because of all these things that happen in the background. So if you can supplement right the folic acid, and then you can, maybe change those medications, tweak them a little bit if it's possible to do so, and then have the kid, it's pretty safe to have a baby, and then keep your seizures under control during the pregnancy. So having close checks with the neurologist, I think those are going to be important, and also perhaps being closely monitored with maternal and fetal medicine.
I just want to add on to that. I agree, it's a slightly different topic, but women with epilepsy are like a special group that need to be monitored. So as neurologists, we always ask if they're planning a pregnancy, and ideally they should plan their pregnancy. Otherwise, use contraception, barrier contraception, because a lot of oral contraceptives can be lowered depending on the drugs that you're on. But ideally, if you plan a pregnancy, then the neurologist can help monitor and put you on proper medications to prevent any adverse effects from seizure meds.
Great point.
Meant on the epilepsy, the pregnancy registries, and the consensus about which medications are safe for women of childbearing years to use, because patient selection before pregnancy is really crucial, because a lot of the defects can happen before you even know that you're pregnant. Dr. Yes.
I'm sorry, what was the?
Well, I was wondering if you could comment on the pregnancy registry and how we narrowed down the medications that we think are safe for women, because some of the fetal malformations, many of the fetal malformations, including spina bifida, occur before you know that you're pregnant.
Yeah, so I do encourage all pregnant women with epilepsy to register with the epilepsy registry, the pregnancy registry. The meds that are safe are Keppra, lamotrigine, and then newer meds we don't know that much about. Zonisamide not that new, but there's not many side effects reported for babies. Outside of that, Vimpat as well as Aptium are relatively safe, but again, there's just not significant reported birth defects with it. So especially if somebody's on a newer medication, I encourage them to register with, it's like a national registry. It's a phone number that I give to most patients. Yeah, the ones to avoid, as you mentioned, are Depakote, carbamazepine. I don't have that many patients on phenobarbital at this point, to be honest with you, and certainly Dilantin as well.
It's the vitamin A with phenobarbital. And so perinatal bleeding is probably the biggest risk with phenobarb. So if someone's on phenobarb, they need to get vitamin K prior to labor and delivery, so that the child doesn't have any issues with that. And what are your thoughts about topiramate? Because that one is a little bit troubling, because the numbers are so borderline, and yet topiramate is a category D drug.
I don't give it either. I think there's better options for the most part. Unless someone has very severe epilepsy, I would recommend Keppra or lamotrigine. Outside of that, Vimpat or Aptium. So I would avoid it if I could. Same thing with Topamax. That can interfere with birth control. So I always, at like a specific dose of like 200 plus. So I also like recommend barrier contraception with topiramate.
We also have to think about our migraine patients that can be on topiramate.
Yeah, and it's not recommended for migraines at all during pregnancy. Most of these meds aren't.
I think the other concern with topiramate is that it does cause weight loss, and weight loss in pregnancy can be detrimental to the fetus. So IUGR can be a theoretical intrauterine growth retardation of the fetus, can be a real concern with Topamax. The other, there are some reports of cleft lip and cleft palate, I guess, with topiramate as well.
Excellent discussion.
Population at large, but I think that was the major driving force for the change to category D.
I'm going to switch gears on you guys now. We have a number of questions that have come in. Dr. Sheikh, I'm about ready to graduate from high school, and I have seen a pediatric neurologist my whole life for my epilepsy. What do I do, and how do I transition when I go to college or as an adult?
So there's a variety of options. One option is to see a doctor who sees both adults and kids. So there are a lot of pediatric neurologists who also see adults, just like Dr. Nagel does. And so it might be, so I don't know what kind of doctor she's seeing right now. If she's seeing a pediatric neurologist who also sees adults, it might be just wise to stay with the same doctor, because they know them for the longest possible time. But if they don't see adults, then I think it's wise to transition gradually to an adult neurologist. Somebody that her pediatric neurologist can recommend, who they have faith in. And we typically make the referral and send all the records before the doctor actually sees the patient, so that the doctor already has a good idea of what's going on with the patient, what their life story is like, what they have been on in the past, what they might have failed already, what options they have in the future in case the seizures get out of control. So it has to be a collaboration between the pediatric neurologist and the adult neurologist. But the best scenario would be to see someone who sees both, actually. If their neurologist is the one who sees adults also, it might just be wise to stick to the same doctor.
And I would like to add a little bit into it. So if you have epilepsy and you want to transition to an adult doctor, adult neurologist, there are what to look for in a doctor. You have epilepsy, look for the doctor if he has training in epilepsy. That is one point. The other thing, when you transition from your doctor to another doctor, if you are moving to another state because of college, and then make sure you get all your previous record, your MRIs, your previous EEGs, your previous medications. So like as much data which you can get from the doctor, because for the new doctor, that information will be very helpful. That is.
Excellent. Thank you. I'm going to open this question up to the entire panel. Two-part question, but we've had a number of questions come in related to this. Can we have a discussion about SUDEP? And during that discussion, can someone comment on a link or trouble using medical marijuana or any benefits with SUDEP?
So I can start off here. So SUDEP basically, it's an unfortunate but a very rare outcome of epilepsy, and so it stands for sudden unexpected death in patients with epilepsy. It's an unexpected, unwitnessed, usually death that is not related to a prolonged seizure and not related to drowning or accident, and usually happens during sleep. About 80% times these patients will die in their sleep, and the presumption is they probably had a seizure and then they stopped breathing after that. And after the seizure was over, they never started breathing again. That's the presumption of how SUDEP happens. Now, what causes SUDEP? It's a very complicated, issue. There's a lot of risk factors. The biggest risk for having SUDEP is if somebody has what's called a generalized tonic-clonic seizures or whole body shaking type seizures. And if those are happening at least 3 times every year or more, if somebody has seizures 3 times a year or more, their risk of having SUDEP is about 15-20 times higher than others who have less than 3 seizures a year. And we're talking of generalized motor seizures, whole body type of seizures. The other risk factor is if somebody is on 3 medications or more. So if somebody's seizures are very well controlled, they're on only 1 medication or 2, their risk of dying suddenly is extremely low. But if their seizures are very uncontrolled, they're still having seizures and they're on 3 medications or above, then the chance of of having SUDEP is about 8 to 10 times higher than somebody who's on very few medications. The other risk factors would be if somebody has seizures starting from early age, like childhood epilepsy, or if somebody has developmental delay, low IQ. Those are all high risk factors for SUDEP. Patients with sleep disorders, possibly sleep apnea, may also be a risk factor for SUDEP. Now, coming to the second part, the medical marijuana, I don't think there is any evidence, at least in my knowledge, of that either helping or making it worse. But we do know from literature that that cannabis can actually cause seizures or induce seizures in somebody who has epilepsy. And so with that risk of having a breakthrough seizure from cannabis, the possibility of having an adverse outcome like SUDEP is theoretically increased. I don't think it's otherwise. I don't think cannabis will reduce the risk of SUDEP.
So each of us have different experiences. So coming to the first point, so the practical point which I give to parents about SUDEP, that make sure when they go to sleep, their bed and the pillows are firm. Don't go for very soft pillows. The other thing, make sure they do not sleep with too many of the stuffed toys. That's another practical point. So and now they're coming back to, so my experience was that, so during my residency, one of a very important, I will not say the name, so very important child in the New York State literally died from withdrawal of marijuana in front of, I saw that case. So the major issue in marijuana is the withdrawal. Do not stop any medicine suddenly. In that kind of situation, what happened at that time, CBD oil was not legal in the New York State, and people were using it just without letting anybody know. And eventually, when they ran out of them, there was no supply. So make sure if you're taking CBD oil or marijuana, so don't stop it immediately, because stopping it will be a bad thing. Like, don't stop cold turkey. That's what I want to say.
Excellent advice.
I would say I agree with Dr. Sheikh as well as Dr. Mahfouz. But the SUDEP's a big area of research still. We're still trying to figure out what exactly causes it. I think the biggest risk factor is generalized tonic-clonic seizures, frequent uncontrolled generalized tonic-clonic seizures. The other risk factors mentioned, like taking a bunch of meds, cognitive disability, MRDD, all of those are also associated with increased seizures, which is, like a risk. So it's hard to say what exactly is a risk factor for SUDEP versus what is correlated with SUDEP, because it's something that patients with frequent seizures have regardless. Patients with frequent seizures will be on 4 or 5 meds, which may not be helping anyway. That's all I wanted to add.
It's also interesting that there are some epilepsy syndromes that are of particular concern. The best example, one that we can discuss with both parts of the question, is Dravet syndrome. Dravet syndrome is a genetic epilepsy syndrome, and the seizures are really hard to control. I have a couple of patients with Dravet syndrome that I follow regularly, one who's in his 20s, and he's having apneas already at night. And the risk for sudden death with Dravet syndrome is extremely high. So he has monitoring at night. He's lucky enough to have nursing supervision at night, and he's on an apnea monitor at night. So we're watching him very carefully. So there are syndromes that we have to be aware of. And the other part is the whole thing with medical marijuana is that there is one preparation that is FDA approved, and that's CBD oil, or Epidiolex. And that's been very well studied. And it's a purified derivative that's only CBD. And we have good data there. As far as other marijuana preparations, there's a lot less study that's gone on. And some of the things that are available over the counter, you don't even know how much CBD you're giving.
So Dr. Nagel, Epidiolex is only available by a prescription, correct?
That is correct. It's FDA approved for Dravet syndrome, Lennox-Gastaut syndrome, and tuberous sclerosis. And while it's not even, it's no longer regulated by the DEA. It's not even a category 5 anymore. So the DEA is out of the picture for Epidiolex. It's still regulated in a sense by the insurance companies, who will often not pay for it if it's not for one of the indications, or at least for an epileptic encephalopathy. It's very expensive, but so are the preparations over the counter. When you look at the amount that of CBD that we're actually prescribing for patients, an adult can be getting 200 to 300 milligrams per dose fairly easily.
And I have a question. Sorry.
Sure.
I have a question from Dr. Nagel. So other than the syndrome, which we know they are FDA approved for medical marijuana, but we often come into clinic with situation when a patient has other syndrome, and patient also has autism, severe behavioral issues, and we want to prescribe marijuana, but we get a pushback from insurances. How do you deal those situations?
Usually on peer review, I have found of late that if I freely admit that it may not technically be Dravet syndrome or Lennox-Gastaut or tuberous sclerosis, if I say that this is a patient with an epileptic encephalopathy, that will frequently get the approval. So I think when I look at this, there was a very good insight from Dr. Kodegal from Cleveland, that he thought it was very interesting when it first came out that you had Dravet syndrome, which is a very specific genetic diagnosis, with 90% of the cases being due to a very specific mutation in one gene, which is SCN1A, whereas with Lennox-Gastaut, there are multiple causes of Lennox-Gastaut syndrome. So if you switch the terminology to epileptic encephalopathy, that will often get people to go along with that, with the certification for it.
Thank you. That's a good point.
Excellent, thank you. Dr. Soraya, why don't I know I'm going to have a seizure?
So the first understanding that one should have about seizure is that it is a subtle and molecular level electrical discharge, which erupts from or comes from a constant balance between excitation of the neurons and relaxation of the neurons. So when the excitation level goes up, one starts to have seizure. Now, when seizure happens within the neurons, by the time it becomes sometimes strong enough, in the general terms, if I could say, or long enough, that starts to manifest as a symptom to me. For an example, if someone has, let's say, a subtle infection in their body, until they start having fever and they kind of start feeling bad, they don't think about that it could be an infection. COVID is a big example for that. Same way, when my brain is starting to have some trouble during the excitation and relaxation, my body or my own sense may not recognize it yet. And therefore, I may have sometimes some warning that something's not right with me, but sometimes it may be so fast, some seizures generalized or spread within the brain so fast that there is no reaction time for me to know, and I may not know it's happening to me. Now, once it is happening to me, obviously the word seize means it takes over you, so to speak. You don't know, you may not remember. And the after effects of those seizures can be known in your body, like you may have a tongue bite, or you may have some injury to you, or obviously someone saw you having one, and that sometimes suggests that you had one. So, it's a complex condition that manifests as a symptom. That manifestation sometimes may not be enough for your senses to know.
Thank you. Dr. Haseeb, you were tackling these COVID-19 vaccine questions so well, I'm going to throw you one more.
Oh my God. Okay, go.
My child is 8 and has completed her 3-stage hypoplastic left heart syndrome surgery. She is epileptic, likely due to a small brain bleed when she was on ECMO. She is on heart meds plus Keppra and oxcarbazepine for seizures. I'm concerned about the vaccine's effect on the liver and blood. Is this as prevalent in the mRNA as it is in the adenovirus vector vaccines?
So she's on Keppra, and what is the other medication you said?
Oxcarbazepine.
Yeah. So means oxcarbazepine it does get metabolized through the liver. But if I'm understanding right, the question is, will the vaccine affect the liver function test? And is that the question, right?
Yes, the liver function test or blood in general.
I mean to say, I don't know if there has been any cases of liver failure with the COVID vaccine. Again, I would have to since it's kind of out of our area of practice, I don't come across this kind of scenarios, but perhaps some others can share. But we have seen like more things from the neurology related spectrum is like strokes, blood clots, things in that aspect. So if you say, some effects of like strokes happening because of ischemia, because of blood clots happening, those could be. But in the liver function area, I am not aware if that would be increasing. And that's why those studies are happening, up until, like, as I said, from 6 months till 12 years, up until 16 years. So that data, when it comes out, I'm curious to see if they'll report what kind of effects they're seeing. The sample size of 6,000, 7,000 children is not that big, but at least we have something to start with in relation with, is that going to be a severe side effect that might be seen in children? Because I'm seeing kids are able to tolerate things much differently than adults. Like a certain doses in adults, they would have effect on the liver, versus kids, I have different doses that they easily metabolize. So that's why I think we'll have to wait for those studies to come back and get a better answer. That's what I would think, unless somebody wants to add something to that.
Yeah, actually from the trial for COVID vaccination, actually they look at, including some patients with liver disease. Actually those vaccinations, they say the safe for the actually looks like it didn't report any liver damage from the vaccination.
Thank you. While we have you, Dr. Zhang, are there any new seizure meds that look promising on the horizon?
Yeah, every year have a new medication come out. So actually, even last year, just a new medication approved. So the actually from the how to say, the most medication approved from adult. Especially the that's why the even like but the last year one medication approved for Dravet syndrome. So that's still for kids, but the majority medication, new medication came out approved. That's why for pediatric side, usually we a little bit delay to use those new medications relatively because we are waiting for data. So whether have a pediatric study and after adult approved.
Thank you.
I would say
Dr.
as of now, the most latest that I use is the Epidiolex, and really means when all has failed, it has really helped for my Lennox-Gastaut patients, and it's really a lifesaver. It has changed, means for those who fail like 6, means obviously the data shows the more is 4 drugs than you, or 3 drugs, and you start that 4th and the 5th and 6th, the chance of those drugs acting is like 2%, 1%, it goes down. But Epidiolex has been a wonder drug for me. It has helped.
Excellent, thank you. I'm going to throw you an easy one, Dr. Haseeb. Can I outgrow my epilepsy?
Depends on multiple factors. So, depend on the age of onset, depend on the type of epilepsy syndrome, depend on multiple factors. So let's start with saying if somebody had febrile seizures and then now they're having afebrile seizures, can they outgrow? If they have a genetic mutation, what's called as JEFS plus, like generalized epilepsy with febrile seizures, and they have a certain sodium channel mutation, the chances to outgrow is less, but it does put them at increased risk for developing epilepsy in the future. On the other hand, if you have the simple benign Rolandic, benign myoclonics epilepsy, so depending on the type of syndromes, then they have a higher chance of outgrowing. So the factors would be if there's a strong family history of seizures, depending on, like again, as I said, if it's generalized epilepsy, so if you had a later onset, less chance to outgrow. I'm just speaking from the aspect of practice. So if the epilepsy started after 14, 15 years of age, the chances to outgrow less. Again, without a brain, we are talking about idiopathic, like epilepsies. Obviously, if you have a structural lesion, then that is going to be the cause, and that will still be there. So someone had a brain bleed, brain damage, that's irritating the brain, causing the seizures and abnormal electrical discharges, that will be there. You're not going to outgrow that, unlikely. Same thing with adult or juvenile onset, juvenile myoclonic epilepsy, juvenile onset epilepsy syndromes, they'll stay. But the benign Rolandic ones, they have a higher chance to grow. But kids who have multiple type of seizures, I see that they have a difficult chance. So if you have absence seizures, myoclonic seizures, convulsions, less likely I've seen that they grow out. Sometimes there's a phase of dormancy where I'll give you an example. I had a child who had spasms until then we did the ACTH. They had ACTH at outside facility, came back to me, and then he was seizure free from age of around about 1 year or 1.5 years till about 9 years. 9 years, the seizures came back and just came back with vengeance. And now he's on like 4 medications. And then we had a vagal nerve stimulator implanted, and still the seizures are there. It's controlled, but not to the best of what the family would be expecting. So still they have about 1 seizure every other week, which is not controlled. It's still intractable and drug resistant. So yeah, those factors play a big role.
Thank you. We are closing in on time, but I want to get one more question, and maybe Dr. Riaz, you can take this one. I take my seizure medicines like I should every day. Why am I still having breakthrough seizures?
Sure. So some people will have epilepsy that's very responsive to seizure meds. A lot of generalized epilepsies are pretty responsive to the first seizure medicine that we try or the second. And when I say try, I mean try at like a proper dose or a maximum dose. Whereas other people, usually about a third of focal epilepsies may have a more aggressive epilepsy that's not necessarily responsive to drugs. So I guess it would depend on the patient. A, are they on a drug that's a good medication for them? B, are they on a proper dose of that drug? So if they don't have side effects, they keep having seizures, I would continue to use the maximum amount that I'm able to. And then see how aggressive their epilepsy is. So a third of patients with focal epilepsies and a few generalized epilepsies are resistant to medications. And as Dr. Teek said, it was you know, if you fail two seizure meds, then you have medically refractory epilepsy, which means the chances of responding to a third, fourth, fifth agent are very low, usually like 3 to 5%, actually less than 3%. So that may be the reason why, but ideally, if we should try patients on proper doses of medications to see if they respond.
I want to open it up to anyone in the audience. We're getting close to time. If you have any questions, please submit them through the chat. And while we're waiting for that, maybe one more question. If I have been on multiple seizure medicines and I currently take more than 2, should I be evaluated for brain surgery for my epilepsy? I'll throw this out to anyone.
Yes, they should. If they failed 2 meds at proper doses, they should be evaluated for a brain surgery. Now, when we say evaluate, you know, that means usually figuring out where the seizures are coming from. If it's a generalized epilepsy, then they're not a surgical candidate. If it's a focal epilepsy or a multifocal epilepsy, then they could be a surgical candidate. And when we say surgery, you can start with brain surgery if it's very focal and it's a straightforward surgery. A lot of patients get a VNS as well if it's, you know, multifocal or if it's generalized epilepsy.
From my surgical epilepsy experience, so the one thing, if epilepsy is focal, the chances of finding the area where the epilepsy is coming from are high. On the other hand, if the epilepsy is lesional, then the surgery, the success of surgery will be more. And also it depends on where. For example, the temporal lobe epilepsy, the surgical success will be high. On the other hand, frontal also a little bit high. Parietal lobe, it's so thickly connected to rest of the brain, so chances will be a little bit low. Occipital lobe, surgical options are limited because the area is so important because of the eloquent cortex, because there is always a risk of losing vision. So we are a little bit reluctant with the occipital lobe. We go with the other options called neuropace. So that's what I want to contribute.
I agree with all of them. So, you know, it's also a very complicated question. Some patients may not respond to medications just because their epilepsy is resistant. So we call that drug-resistant epilepsy when they are resistant to 2 drugs. Some patients may actually have an incorrect diagnosis of epilepsy also, and they don't respond to medications, and they continue to have seizures. What are called seizures may not actually be epileptic seizures. So, you know, when they fail 2 medications, they should basically go back to their epileptologist and get reassessed. They should second question the diagnosis, check it again, confirm the diagnosis. If it's indeed epileptic seizures and they have been on 2 drugs at maximum doses, then I think that's the spot, or that's the point to start talking about epilepsy surgery if they are the right candidates.
And one more thing I'll add to that is, you know, sometimes if and 2 medications, you're right, and that's why it's really the definition makes sure it says 2 appropriately tried medications, which means for the right epilepsy syndrome. So if someone has generalized epilepsy and you try oxcarbazepine is for partial epilepsy. So that's where you then want to make sure that, you know, a right medication was tried before you call it. So yes, after 2, you can do it. Could you try? So I would say, you know, always say, take a second opinion. That's what I said. I would do what I would do for my family is I would take a second opinion from somebody else and say, hey, are these the right medications? Then the first question the neurologist epilepsy trained doc, as Dr. Mehfooz said, is you want to go to someone who is trained with epilepsy or experienced with epilepsy. Nowadays, even once you do enough experience, then, you know, you are pretty good. So, and if I have enough experience with epilepsy and I say, oh, this was not the right medicine because your EEG is showing so and so, and we change the medicine, boom, that's an easy fix. Why go in for a brain surgery? But yes, if you continue to remain intractable, then you got to explore the non-medication management techniques, and surgery would be one. Vagal nerve stimulator is one, because, you know, some patients feel more in control when you have a VNS. You can swipe the magnet, stop the seizure, versus going for a big brain surgery, because brain surgery is always an option, but, you know, maybe the VNS will control it. And then diet changes. So all these things, you know, combination, you could do some of that. The ketogenic diet is granted ketogenic as diet is tough, but maybe even if you go with modified Atkins or something as close as you can get, reducing the carbs and increasing, you know, your protein intake and some fat intake, I've seen that also makes a huge difference. Reducing a potent antioxidant diet. makes a difference.
Excellent points.
Yeah, I think a failed second drug trial, and again, making sure that you chose the drug appropriately and don't include drugs that were discontinued because of side effect issues, should lead to kind of what I call outside the box thinking. And that includes epilepsy surgery, vagus nerve stimulator, DBS and neuropace devices, also the ketogenic diet and its variants. And I put Epidiolex in that outside the box area. That's at least the way I approach it with my patients. But I think you fail 2 drugs, you really need to look at all other options.
Great point. Well, we are at time, and I want to thank all of our panelists, Dr. Zhang, Dr. Mahfouz, Dr. Nagel, Dr. Sheikh, Dr. Soraya, Dr. Riaz, and Dr. Hasib. Thank you for your time and all the excellent answers, and I will turn it over to Roy.
Well, thank you, Nicole, and thank you to the panel of doctors. The amount of brain power we have on this Zoom is incredible, I have to say. So I want to thank every one of you for taking some time out today in a Friday evening to participate in this event. I want to thank everybody who did participate and who submitted questions. Like I said, we have this recorded and it will be available for other people to view in the future. And I think it was a great discussion. So I want to thank everybody. And yeah, so hopefully we'll be able to do something similar like this again. So thank you, everybody who participated. Thank you very much.
Before the opportunity.